Switzerland, I have the privilege to be able to accompany people in these kind of explorations, different substances. We have to work with, it's important to tell, with the government authorization. We need to get the approval of the government for every patient and all the substance we can then order in a pharmacy, and then we have to accompany that. I have to accompany that the most possible way.
Mm.
The trauma, the stress is so dense, and the information is so heavy that the organism cannot treat that information properly, and then there's a lack of integration. We pretend that everything is fine, but most of people would admit somewhere that they're suffering at their work. And our culture is based on trauma, and that's why we, as a species, in our collective culture, we are destroying the basis of our life. The real margin that people have, that we have, is very low. It's maybe 5% of our capacity that we can invest in doing things differently. To ask yourself, what things in my life can I do differently than I'm normally doing?
This content is intended solely for informational and educational purposes. It does not in any way constitute an encouragement to use illegal substances, nor does it offer medical advice. If you are experiencing psychological or medical issues, please consult a qualified healthcare professional. Some of the substances mentioned are legal in certain countries and illegal in others. It is the responsibility of each individual to comply with the laws of the country in which they are consumed and to undertake any experience in a safe and appropriate setting.
Good morning, Ansgar.
Bonjour et good morning, Arnaud.
Very nice to meet you.
The pleasure's on my side as well.
Okay, so we meet here in Lausanne, in Switzerland. So I came here to talk to you about your new book. I mean, it's not new, but it will be new in the French language, but it exists in English since a while. Vampirocene. So maybe before we start, I would like to do something I do usually in my podcast, which is to maybe share a vulnerability. Both of us, I will share one, and you may share one too. Because yes, usually opening by the vulnerability, and you speak of that in your book, is a way to open our heart and maybe to go deeper into our own truth. So I'm gonna start with a vulnerability I would like to share, which is that this morning actually when I came here, I was thinking that I discovered psychedelics rather late in my life, and it totally changed my life. And I was a bit sad that I discovered psychedelics so late in my life. I was thinking that if I had discovered it earlier, maybe my life would have been different. And I see so many people in the psychedelic field today that are young, they are something like 30, 35. And I find them so lucky to discover psychedelics so early. So there's this bit of sadness that I had this morning thinking about that. And at the same time, I thought that the fact I discovered that so late also is a reason why I'm so passionate about it. Because the suffering I went through during my life, as it lasted a lot of time, maybe it created also the energy that I have now in order to spread the culture and information about psychedelics. So it's a bad thing for a good thing, maybe. But there was this little sadness and that I had this morning. That's what I wanted to share.
Thank you. From my side, what I can share this, I saw a television movie yesterday evening that it's a German production. The name is Vatersland, the land of the fathers. That's the title of that film, and it shows the life of a woman in her 50s that goes into memories of her childhood in Germany, typical German childhood in the area I was born, Cologne. And she describes very drastically, we see scenes of a very disturbed parental education model from her father, especially. He was abusive towards her, not sexually, but emotionally abusive. And he sent her at some time into a Catholic school. And that's where also there was a lot of stress in that surrounding. And so she's describing her youth in Germany, and I felt very much remembered of my own, if you want. And luckily, she was able to get out of this when she was getting adult and finding a relationship, healthy relationships. But it was very courageous of her to present this difficult part of her normal German childhood, we would say, in the terms of emotional neglect and abuse. Yes.
Mm. Okay, yeah, thank you for that. Yeah, it's usually it's very, and that's what you speak in your book quite a lot, is that the fact it's very courageous from an individual or from society to face the darkness and the difficulty. And that's that. I think we'll come back to that later on about your book, because that's maybe the main difficulty that we are going through right now, is the ability to face.
Yes, especially when they are not very extreme forms of violence, like sexual abuse in that case of that movie, but it's a subtle form of not responding to the needs of a child. And I would say that even people that have the luck not to be born in very highly dysfunctional families, but still there's this culture of neglect and emotional abuse in our culture very deeply, and I think we need to address that.
Yeah, totally. I will be agreeing with you most of the podcast, because I read your book, and it's amazing. It's really, there's so many things which are so interesting, and that really reflect something that I've been living myself so around me. So I guess I will be agreeing with you most of the podcast on your theories. But maybe to start, before we talk about your book, may I ask you maybe to present yourself?
Yes, my name is Ansgar Rougemont-Bücking. I'm a psychiatrist and psychotherapist living and working in Switzerland. I am originally from Germany. I emigrated to Switzerland in 1999. So it's about 25 years ago. And yes, in my career, I was at the beginning working with drug addicts, severe drug addicts in Lausanne, heroin, cocaine. And I realized that these people are traumatized. And that's why I got interested in psychotraumatology. I was lucky to be able to make a scientific sabbatical year in Boston. I did research at Harvard University about PTSD, and I was doing a training in Bethel von der Kolk's Trauma Center Clinic because that was my interest at that time. And then I go on training myself. I learned EMDR, eye movement desensitization reprocessing, and a couple of years later, I was lucky to discover the psychedelic approaches in psychotherapy, and one of the doctors in Switzerland is practicing this for a couple of while.
Okay, perfect. That we will talk of this. We'll talk of this. That's really interesting. As I say, usually talking about podcasts in Switzerland, is that Switzerland is really the country in the world which is the most advanced in terms of psychedelic therapies. That's not well known, but that's a truth. That's a truth. When studying, all countries and all contexts, for sure, Switzerland is one of the most advanced countries in that. So yes, I would love to have your insights on that. And also maybe to remain on the personal side, did you have in your life sometime something that you could name a tipping point, which is you arrived to a situation that changed your life, and that where there was a before this event and there was an after this event, and your life was not the same? Did you have such a tipping point, and can you share it with me?
Yeah, it's a difficult topic, I would say. I think it was about 12, 13 years ago when I had a very difficult separation and divorce, where all of a sudden I had to struggle in order to keep contact with my children. That's for me totally not possible to imagine that it would be so difficult to keep contact with my daughters. And at that time, I also had a severe professional crisis, being bullied at work, and I had to fight on several levels in order to keep my position and my contact with my girls. And this was so heavy because until that, I always functioned very well socially. I made everything how I was supposed to do. And all of a sudden, I had all these problems from in a very short time, all these enormous problems, existential problems. And that's why I said, well, I want to understand what's going on here. Why get into this kind of relationships that end up like this? And what is going on with me? And why do I live in such a mess at the moment? That's why that's when I got interested in other forms of psychotraumatology, breath work. I did breath work, and then I got interested in psychedelics.
Mm. Okay. Yeah. Thank you for sharing that. And that rings a bell personally also, because I had such crisis also with the divorce and same time professional difficulties that were a tipping point in my life. So it really resonates with my own life. And thank you for sharing that. I think that's important to share this, because people can sometimes, when that happens, you don't understand what happens to you. And when you see that it happened to other people, and specifically people that are like you, a renowned psychiatrist, that can help people to better accept this situation and go and explore in themselves maybe the darkness and the traumatic imprint that they can have. But we'll speak of that later on.
For me, it's important to point out that it's not so much about saying, okay, this is a very disagreeable situation and these people are mean and I'm mistreated here. But for me, it was to understand how was it possible that I got into these relationships and I stayed in relationships where I maybe should have seen warning signs, but I didn't notice. I didn't respect myself. And this is what brought me up to do these kind of new approaches in order to better know myself.
Okay. And what about your experience with facilitating psychedelic experiences with your patients here in the Switzerland? Because it's you have the legal right to do that. Can you explain first what you can do here in Switzerland with your patients?
Yes.
And also maybe talk about the experiences that you had, and maybe, of course, keeping anonymity and not disclosing anything that could be a problem for anyone, but maybe share an experience that has been really interesting for you to facilitate.
Yes, of course. In Switzerland, I have the privilege to be able to accompany people in these kind of explorations, different substances. We have to work with, it's important to tell, with the government authorization. We need to get the approval of the government for every patient and all the substance we can then order in a pharmacy. What can I say? Well, it's always interesting in the follow-ups when the people are regressing in age during the sessions, and then all of a sudden there's coming up something quite ancient and often a situation of being overwhelmed in something very emotional, and where the people are living the panic or the stress of that situation in real time. Then it's just popping up like a theater play, and then we have to accompany that. I have to accompany that the most possible way.
Mm. And do you have any preferred substance that you like to use with your patients for any reason, or maybe substance that you use for specific situations and other that you would use for other situations, or is it the same for you?
I always go gradually. I normally only accept this kind of therapy for patients I know very well that have been follow up for quite a time already. And normally I also send people to go breathwork somewhere, send them to colleagues that can do breathwork with them. It's probably the first entering into this kind of modality. Then I always do several sessions with ketamine, something that's approve a lot kind of experience. It's not too long, it's not too heavy. And then if the ketamine process goes well, I propose MDMA normally. It's the first special substances in Switzerland. And then later maybe after the MDMA, LSD or psilocybin.
Okay, that's interesting. So you start with ketamine actually, more than MDMA.
Yeah.
Okay. Is there a reason why you prefer to start with ketamine than MDMA? Because MDMA usually is the reputation is that it's easier, specifically for trauma, revealing an easy substance. Is ketamine for you a better way to start?
I think it had lots of advantages. It's quite short in the duration. It's not expensive as a substance, and you can use it in addition to all kind of other medications. So you do not, like MDMA, you have to take off the antidepressants for a while. Can be difficult for some patients to do. So with ketamine, you can just add it, and you can already discover and explore altered state of consciousness state with your patients, which is intense, but not too long and normally not too challenging. And I think there are lots of things already happening with ketamine, and you can work very well with that substance.
Okay. And between LSD and psilocybin, which are regular, what we call regular psychedelics, what makes you choose between them two, depending on the situation you have in front of you?
Maybe I would rather opt for psilocybin when there are lots of somatic difficulties, suffering in the body.
Okay.
Psilocybin is quite intense for bodily exploration. LSD is more maybe intellectual rigidity, that people are thinking in a certain way and are blocked in this. Maybe I would rather opt for LSD. But both are fine. But another kind of disadvantage of the LSD is that it's quite long, very long sessions, 10 hours or more. So this is sometimes, there is some advantage to shorter session psilocybin.
Okay. And so something also that really I'm interested by your experience on that, because yes, you have a broad experience of, with various substances and things that you've been administering legally. So it's really interesting. That's why I think it's important to share it, because it's so exceptional that you can share it, publicly. So what about, there's something that happens sometime with psychedelics is the revelation of a traumatic amnesia. About abuse, for example, or something usually in the childhood, or most of the time it's something that happened in the childhood. With your patients, did you have some kind of revelations like this with your patients that discovered something that they had in their childhood and that they've been forgetting? And second, did that happen with the first experience, or do you need to have several experiences before having such a revelation? What's your experience on that?
That kind of depends. It's very difficult to predict. That can sometimes happen in the first session, that people realize something they had a little bit kind of forgotten. But it's not so typical that comes up in the very early phases. I always refer to the idea of the inner healer. That is this authority somewhere in the mind that is kind of controlling access to difficult content. And it's always the question, is the organism able to hold that information, to keep on? Because I think we have a economicity of the brain, of the mind, of the soul, that we try to survive. And in order to survive, sometimes we have to protect ourselves, and we have to respect, as a therapist, also this protective necessity. So I think I have to be very careful when it comes to getting out of amnesia. But sometimes it happens, and we have to be very careful not to direct that in a certain direction. We have to be very cautious about interpretations. It belongs to the interpretation of the understanding of the patient. It's not mine. It's not my agenda that I want to reach something in that session, but it's the inner healer of the patient who's doing the work, addressing a little bit maybe. And then we have to, the most important part, integrate that in the daily life. That means what are the things I have learned and seen? What are the consequences for me in my daily life, in my relationship, my private relationship, intimate relationship, family, work, everything? What maybe should I address and clarify in my daily life here and now?
Yeah, totally. And you were saying just before that, in your experience, also for you, you had to integrate an experience. Sometimes it took you months or years in order to fully integrate and understand an experience. And that's something that is really important to say to people that envisage a psychedelic experience, is that it's an intense experience. It's something that can change your life. And at the same time, sometimes it's difficult to make sense of it. Because the information, as you said, maybe the inner healer is not ready for this information. So sometimes it takes some months or years to integrate and understand and make sense of an experience. And for me, it's the same. My first experience, it took me years to understand fully what happened during this experience. And as you said, it's an ongoing process anyway. I'm not sure we will understand everything that we've been experiencing during our experiences. All right, so thank you very much for this first part. So now I would like to talk about your book. So this is the book in English. There's a French version that is coming out right now, so which is the same name, is Vampirocene, but the subtitle is a bit different. You were telling me is slightly different. Now in English, it's How Structural Traumatic Dissociation is Leading Society into a Spiral of Violence. So it's really a very, very interesting book. It's fascinating. I mean, there's so many. It's very dense. So, it took me time to go through it little by little, but it's really, really interesting. So I'm really happy that we have the opportunity to talk about it. So maybe first, can you explain to me why you decided to write this book? Because it's a lot of work. I mean, I can't imagine how much time you dedicated to this book. It's a lot of work. It's courageous because you expose some ideas which I think people could find sometimes challenging to accept. It was not for me, but and that's in the basis of what you're describing. The traumatic dissociation leads to have difficulty to face maybe some stuff that you say in your book. So it took you a lot of time. It's very courageous. So why this book and why this name?
Yeah, this book is my contribution as a human being, as a citizen, as a father, as a psychiatrist, as a psychotherapist, to the global crisis, to the meta crisis we are living in. And I started writing it right on the beginning of the COVID crisis in 2000. I started to write it in March because all of a sudden we had time. And I kind of was writing things that I've said and just explored in conferences I've given in the previous years about trauma, addiction, consciousness, and I was putting all these ideas together, and I had this understanding of in which way is trauma manifesting today, which are the contemporary forms of trauma that we can see all around us, and maybe we should have a closer look on them. And so I was describing these traumatic archetypes, and I summarizing the whole thing as a Vampirocene. And the Vampirocene is the idea that we call our time sometimes Anthropocene. You maybe have heard of that term, that we're shaping the planet Earth by our culture in a durable manner, in a probably more negative manner than would be. And this is what we call the Anthropocene at the moment. But in my understanding, what we call Anthropocene, we should rather call it Vampirocene, because it's a culture of division and dominance and of maltreatment, and it's based on trauma. And our culture is based on trauma, and that's why we as a species, in our collective culture, we are destroying the basis of our life on that earth, and we will probably pay very, very heavily in the next couple of years for that. And my idea is to call that problem by its root, because I think there's a vampiric, narcissistic, exploitative logic of taking advantage of others, people or animals or plants. And this is not doing any good to us at the end. This is what we observe at the moment. And for me, my dream or the vision I have for the future is that we will be able to get along in a healthy way, with a healing way, with the Vampirocene, and go enter as a species in the real Anthropocene that is still yet to come. Mm. This would be a culture of support, participation, more focusing on well-being and ecstasis, and less on suffering and sacrifice.
Mm. Okay. So maybe we could give some kind of examples also to people that are listening to us about what is trauma. As we were talking just before this podcast, we were having a coffee and talking about the fact that trauma is something that is not well known in our current society, even in your field, in the psychiatric field. It's something that is pretty newly, it has been known for a while, for decades, but coming into the general knowledge is something very recent. So people maybe are not familiar with this notion. So maybe you can talk a bit of what is trauma and how it manifests in our lives on an individual basis or collective basis, just to give an explanation of that, and maybe also give some example later. But maybe first a general explanation of what is trauma and how does it manifest in our lives.
Trauma, the definition of trauma I apply is the one from Pierre Janet, the French psychotraumatologist from the 19th-20th century. And he defines trauma as a lack of integration. So normally the body, the organism has a capacity of integrating, of digesting information, and normally it does it in a natural way. Everything's fine. Once you digest, even stressful events can be digested by the mental apparatus, and then the person is doing fine with even stressful things. But the trauma, the stress is so dense, and the information is so heavy that the organism cannot treat that information properly, and then there's a lack of integration. And the lack of integration then manifests in forms of dissociation, because the information that cannot be digested is being put in something difficult to approach. It's kind of a secluded way, and it keeps on living in a way of a haunted identity. I think that will pop up difficult parts, but the basic problem is that this information cannot be integrated. So it's a lack of integration.
Okay. And so what kind of and something also I read in your book, which I found amazing, disturbing but amazing, is that there's some evidence, or I think it's a scientific evidence, that morphine could be interesting to be administered to someone who has been experiencing a traumatic experience in order for them to integrate the experience. That's something I never heard of that before, but I found that really interesting, because also it's dealing with a kind of taboo of opiates, and we can talk maybe of opiates later on. So just maybe we can make a little pause on that. What's your experience, or what you know about the fact that morphine administration could be useful for someone who experienced a traumatic event at some stage?
Well, the underlying idea is that when the pain is too much, when something is too painful, then the organism is overcharged. And this is exactly the mechanism that brings of the lack of integration, because it's too painful. And if we can manage to lower that pain, also by applying opiates for people being traumatized, then the system is less overcharged. And there are studies that show that if you give people in the emergency room opiates, they have lower chances, a lower risk to develop PTSD later, because the pain system is better regulated by these substances.
Okay, but I'm sure that now a lot of people will say yes, but be careful, because then with opiates, they're going to become addict. So what do you say to that?
Of course, it's true. You can become addict with these kinds of substances, but you have to, you would say that you have to measure the pros and cons of all the interventions. And in my opinion, if you let a person without protection when the person is overwhelmed and at risk to develop long-term sequel from that situation of overcharge, then there might be a good reason to give for a couple of days or a couple of hours such a substance in order to soothe the system down and allow that person to heal better in a better way than without that kind of protection.
And anyway, what is the percentage of people that can become addicted to morphine or opiates in general?
I think it's very important that we not only look at the substance itself, but we look at the context in which the context in which the person discovers that these substances are having an effect on the mental equilibrium. And we know now that the most important factor predicting the occurrence of addiction is trauma. People are taking drugs because they can deal with the sequela of a traumatic state. That's one of the reasons, most important reason why people are taking substances and keeping them.
So what you say is that maybe, Maybe in these experiences where people experiencing a trauma and then take morphine or opiates just after, the risk of becoming addict is less important than in other situations, or it's the same?
There's less risk that they become traumatized, that they develop a PTSD later, because they have taken care of in an adequate way. Of course, it's not only substance, but also taking care of the person. Showing that he's or she's not alone, that there's support, social support, there's the end of the situation, and maybe that the perpetrator is getting punished. All this kind of taking care of a situation of overcharge is important to communicate to the victim in order that the victim is not developing a stress-related disorder later. And I would say that if you really support the person in an adequate way, that's the best prevention of PTSD later and the best prevention of becoming addict later.
Yeah. So it's I understand what you mean. So for now, it's a way to prevent them from becoming addict in the future potentially.
And you're not becoming addict from opiates if you just take them one or twice in the medical context. The problem is that people discover these substances in the normal life context, and then they get addicted because there are no better solutions they can find.
Yeah. And also there's different kind of opiates. You're speaking in your book of some opiates that are less addictive, like, I can't remember the name exactly, but there's one you mentioned, buprenorphine. Yeah. So what is this opiate? Is it what's the difference between this and morphine, for example, or heroin, or those other kind of opiates?
Well, the big advantage of the buprenorphine is that it's yielding a threshold of action in the brain that is protecting the brain, the organism, not to go in overdose.
Okay.
It's safe.
Safer.
It's a safe substance because you cannot go into overdose with that.
Okay.
That's one of the.
And anyway, in terms of addictions, I discovered recently that opiates are less addictive than, for example, nicotine or even, I think, alcohol. That was a surprise because, and was really surprised when I read that. I think for cocaine, it's something like 15% or 20% of people that can become addict. Whereas I think for nicotine, it's more in the kind of 32%. So, of course, one could say that nicotine, okay, if you become addict, it's maybe less dangerous than if you become addict to opiates. But still, that I was really surprised by this information. And that's also something that is not known from the general public. There's this kind of fear of addiction, the taboo of addiction. And it's not only addiction, it's a general taboo about drugs. Opiates, psychedelics, which are very different drugs. Actually, I don't want to talk of them in the same category because it's so different. But still, it's forbidden drugs. So, what can you tell us about that? About this taboo around drugs, around opiates in particular, and what are there also? Are there now in science good hopes of being able to use, for example, opiates in certain conditions?
Well, there are some rare few studies that show or that are suggesting that it might be even useful to apply opiates in people that are living a severe suicidal crisis. They want to kill themselves. And that might be a very efficient treatment to soothe the pain so they're not committing suicide. So we could save many lives with that, in my opinion.
Mm.
And there are also a few studies that are suggesting that we might even be good treatment option for chronic depression. That people are really in this chronic state of pain. Depression is a pain state, basically. And why do we not consider soothing that pain with opiates? Because, of course, we are afraid of creating an addiction. I understand that. But what is the real big problem with being addicted to opiates when it's well managed? I always bring in the comparison with insulin. There's insulin deficiency where people are in risk of dying from metabolic deregulation of their metabolism, and they can die from that because there's no insulin. We can also bring the analogy that maybe people in chronic depression and they have often been traumatized. There's a mismatch of the presence of opiates in the brain. We call them endorphins. And that's why phenomenological, clinical, these people are very depressed and they want to die. They're suicidal because there's so much pain. And maybe we could soothe that pain and give these people a decent quality of life if we apply these substances. But there's a huge taboo because we don't want to make people addict, of course, of substances. Of course, I understand that. But we have to really weight the pros and cons of all these approaches. And in my opinion, it's worth considering that maybe a person can choose, I take opiate medication every day, maybe for the rest of my life, but I have a decent quality of life and I'm not being in pain all the time. And maybe the less people will commit suicides and there will be less traumatized people in the families where family members commit suicide if we do this kind of, for me, this is a pragmatic approach.
Yeah, totally. And it's very strange because, as you say in your book, it's accepted socially that morphine or opiates can be taken for physical pain. That's okay. Everybody knows that. I've got a cancer and, it's so painful. Okay, I will receive morphine and it's fine. But when we're talking of psychological pain, then no, that's not allowed. That's not good. Why do you think there's this difference between the physical pain and the mental pain or suffering? You make a difference also between pain and suffering, which is really interesting. But I guess in this case, we would say maybe psychological pain. Why is there this difference socially and medically speaking?
I think we have a culture where you're not really aware of even the evidence of so much pain. We are so much used that life is painful. That is kind of a mantra we have in our culture. And for me, it's also related to the Abrahamistic religions, where it's normal to suffer, to go in self-sacrifice, and to do difficult things. So we really don't have an awareness how much unnecessary pain we are inflicting on ourselves and on others in daily life. And so it's kind of normalized to be in mental pain, too difficult. And maybe the physical pain, I think, what's probably made the same for many, many years. But now, luckily, in the last 30, 40, 50 years, there was a big campaign of sensibilizing doctors and public about the reality of physical pain. And so people are encouraged to manifest and say, I don't want to suffer. But we do not have allowed and entitled people to do the same when we talk about psychological pain.
Yeah, but it's true. But actually, for example, antidepressants for people suffering from depression, so it's a pain, it's a psychological pain, that is accepted to give antidepressant for people to be a bit numb, because the thing with antidepressant is that it numbs people. As when you say opiates is not numbing, it's just targeting more specifically the pain. That's an advantage you give to opiates as compared to antidepressants. But antidepressants are much more accepted socially. Is there any reason? Do you see any reason why?
Because I would say they have some efficacy in, as you said, to numb the emotional experience of the person, so the person is able to function as normally, because he's or she is less feeling the pain or the difficulty in their daily lives. And I think this is something that was kind of constructed in the narrative about what is psychotherapy, what is pharmacotherapy, that we allow people to function and to go back to work and back into family roles. And then this is considered to be a healing even, or good treatment. But we are not really aware of the phenomenology of the person, who still may be able to function, but still is in loss of sense, and still the pain is somewhere present, but less obvious to the person herself, himself, and for the next people around. So I think there's still this the problem in our psychiatric culture that we have not really integrated the phenomenological subjective experience of the person that is suffering from depression. We have favored therapies that are globally numbing people up or showing them how to function in with their suffering still ongoing.
Okay. And what about opiates? So because we say, obviously you're saying that maybe opiates could be an option for people who are in deep depression or maybe just after a trauma or whatever. What are the possibilities for people to be medically treated or, legally treated with that Is there opportunities right now, or is it still forbidden and you were just regretting that it's not possible? Do you have, for example, you in your practice in the Switzerland, can you prescribe some opiates in some situations, or is it forbidden? What's the situation here?
As you said, there's no formal indication for using opiates for psychiatric suffering beside addiction. Addiction we can substitute. That's okay. That's fine. That's a good thing that we have that. But there's no indication to treat a depression with opiates. In my practice, sometimes I have people that have both depression and a pain syndrome, also psychosomatic pain, sometimes pain disorder, very, very difficult to treat. And in these people, I sometimes encourage take a opiate medication, and the people realize then that both the psychological pain and the physical pain is soothed by these treatments. So I observe that in some of my patients that they get better not only on the pain level but also on the mood level with these substances. And I encourage people to take this substance without feeling guilt and shame, because as soon as people are considering taking opiates, not only for physical pain but also for psychic pain, there are lots of all this dogmatism, the stigmatism about these substances is bad. You're a drug addict. You're a weak person. You have a personal failure because you need the substances. It's very deeply anchored in our culture, and people, of course, the patients are getting activated in this guilt and shame, and this is a very important psychoeducation work I need to explain to these people that the real problem is a disbalance their brain chemistry and opiate system.
Okay. So back to trauma. What is I found also interesting in your book is that trauma is often related to childhood, by abuse or neglect, or there's a lot of possibilities of being traumatized during childhood, which is a difficult trauma because, as we were speaking of amnesia, and I guess that you give a statistic which was amazing. Is that I can't remember which country, but there was a study where they studied girls that have been abused during their childhood, and there have been police and juridic, court discussion and proofs of that. So it is confirmed, and still they'll be interviewing the girls or the ladies 17 years later, and an amazing percent, I think it's 40%, almost 40% of them had forgotten the abuse, where this abuse had been known in the family because it was written on police reports or at the court. So the trauma had been revealed, but then forgotten. So there's all the people where the trauma has not been revealed because there was no police, there was no court, which is, I guess, most of the cases. So it's even worse because then, you could say that it's easier to forget than it's when it's not brought up to the consciousness. So it's amazing to see this percentage. 40% is crazy. So yes, so of course, trauma in childhood is difficult. There's amnesia, so it's difficult to process and everything. But what you're saying in your book is that, so also it's limited to a certain part of the population, maybe a big part, because when you see that it's 40%, or when you see the statistics, for example, that I think I don't know where it's coming from, but that's 10% of girls would be subject to incest, for example. That is a crazy amount. So and maybe it's bigger than that because there's the amnesia. So it means that some people would not even remember of it. So maybe the number is greater than that. So, but still, it's maybe a minority people. But then what's interesting is your book is that you say that there's another trauma which concerns almost everyone, which is the work trauma. So can you tell us a little more about this? What is the work trauma? What do you mean by that?
Yeah, for me, it was a long time. That was for me the question when I was getting interested into the model of structural traumatic dissociation. I was wondering where does this manifest in our daily life for everybody? I was not clear for that for many time until the day I read an interview about the book from David Graeber, Bullshit Drops. And this opened my eyes, and I said, well, this is exactly the way he describes the tragedy of normal work culture. This is exactly what corresponds to this traumatic dissociation. As we pretend that everything is fine, but most of people would admit somewhere that they are suffering at their work. Lots of strain, of a discrepancy between the moral standards of a person and what is supposed to be done at the workplace. And if people, they cannot say no. There's no consentment at the work. You just have to obey and do the orders and work more and work harder. And I think we all know that we have a big pandemia in the world with burnout, depression. People are no longer able to work the way it's considered normal. They're getting sick. They are on sick leave for months, sometimes for years, and many people are not able to go back, so deeply traumatized. And I think we need to address this as a problem of traumatic overload. And this was getting clear with me with the book of David Graeber, and then I checked in my own life, I checked with patients. This brought me also to mention that it's my book.
Yeah, I found that really interesting because it really concerns everyone. There's another figure that you give in your book, is that from, I think, an author that says that 50% of jobs are bullshit jobs. That is, and I'm sure it's going to talk to people because we all know that in our job way of doing work, and you said it was true for you too. I think it's true for me too. We have some time where what we do, we know that it's not going to be useful. It's bullshit, but we have to do it because that's the way it is done. And I find this number amazing. It's really triggering and interesting. And also, what you say is that that's 50% maybe of what our work activity is bullshit activity, but at the same time, maybe it's worse than that because some people that would work for some industries that are maybe 100% bullshit, I mean, not bringing any value to the society. Those people, even though it's you give the example of people who work like cleaning companies. When you say a cleaning company, you say it's useful because people are cleaning, it's operational, it brings, they get the dirt out of the offices, so it's useful. But actually, if this company is working for a bullshit company, then it's bullshit work, even though it's a useful work. So I hope that we're not getting our viewers and listeners lost on that. But if you're lost, you need really to look to read the book from Ansgar because all that is explained and in much details. It's really interesting. So yes, these bullshit activities, bullshit jobs, bullshit work. What can you tell us about that? And how does it contribute to a kind of collective traumatic dissociation?
Well, as you said, there are lots of activities that do not bring really advantages to society, really damaging society, and they're very well paid, like in finance or in the big companies. Lots of things that are done are just serving to make money, but not to improve anything. Or they just extract things and destroy the environment that we know. But there's still so many people working in these areas, and also that people that working, as you said, for cleaning or for catering or piloting airplanes in running that system that is basically not really necessary for a good life on Earth. And the same applies to my own profession as a psychiatrist. I would say that 60% of my work is bullshit work because I do have to do follow up patients that have been traumatized, and instead that we acknowledge the trauma they had lived and we try to make it better, we treat them as they would be depressed, and we put them under medication, and then we ask them to go back to work. But we're not asking, maybe they were traumatized at that work and we should maybe not go there again. But it's from a psychiatrist to restore the working capacity of my patients, regardless whether they've been traumatized at their workplace or not, So I do things that are even morally questionable.
So what's, maybe people will think, okay, that's all good. I can understand that. There's some trauma associated with work. There's some trauma from childhood. There's trauma from neglect. Also, you're talking about trauma coming from neglect, which is also something very common, not reserved to people who are traumatized during their childhood. You're speaking also of the collective neglect, the fact that we individually we can have suffered from neglect from our caregivers, from our, when working in a company or whatever, but there's also the collective neglect where we're neglecting some things which are really important, dealing with nature, for example. So maybe people will think, okay, that's all good, I understand that, but what can we do? What can I do as a worker, as a family, father or mother? What can I do in order to work on my traumatic dissociation and maybe the collective traumatic dissociation? What can be done?
Quite difficult. I think the real margin that people have, that we have, is very low. It's maybe 5% of our capacity that we can invest in doing things differently. That's always my suggestion, to ask yourself, what things in my life can I do differently than I'm normally doing or I'm supposed to do? Without, of course, always respecting the laws and social conventions, of course. But maybe there's a certain margin in my life where I can start doing things differently. My relationships, my engagement for work, my leisure time, consumption, and to try to make things a little bit different than I'm used to be. I think this is what I call the inner healer that is suggesting me sometimes every once in a while, and we can experience that also in psychedelic experience, that there's a suggestion, maybe you should have a look at this and this relationship, maybe you should clarify this and this with that and that person, maybe you should respect better yourself. And I think we can do things a little bit differently, and if we all would be daring to do that, we could already change a lot.
Yeah. And also you're talking of something I really found interesting. I'm always telling that it's interesting, but really your book is so interesting. It's the intellectual prison that you're talking about, which is, I guess, from my experience, I would say related to traditional therapy, for example, or which is that we can understand something intellectually, but understanding it intellectually is not very useful and sometimes can even be a prison. As compared to understand, for example, from our body, or what I would say deeply inside, like with psychedelics, for example, or body work or breath work or whatever. So there's this prison that we have, and there's another prison that you describe, which is also, it's really struck me. It's the prison of people that have been traumatized. So they were victims. So they developed a sense of guilt or shame or whatever. It can be fear also. There's a lot of emotions that can come out of abuse or of trauma. And because of that, they're going to become abusers themselves, perpetrators. And when they do that, they enter in a real prison, because becoming a perpetrator means that the guilt and shame will be very difficult to overcome that. And you're talking of that also for women, for example, because it's dealing with children and that have been assisting to abuse on their children. Once they have been seeing that and not responding, not defending their children, then it's a prison for them. It's very difficult to get out of that because the guilt is extreme, because it's dealing with children, for example, which is important, really for maternity. So that's the kind of prisons that we are in, and that maybe explain why it's so difficult to come out of the traumatic dissociation. What can you tell us about that, this prison, and how to, there again, is there a way to get out of this prison? I would say on my side, for example, coming out of the intellectual part. So it would be going into bodily practices or psychedelic practices or breathing practices or yoga, all those kind of stuff where we're relating to our body more than to our minds. Would you think that it's a good way to do it? And do you see other ways to do it?
I think the most important part is putting the light of attention, of awareness of these difficult and obscure part that we all carry in us, and which I resume as traumatic attachment or trauma bonding. That we have normalized being part of an abusive system, and in our adaptation to that systems, we typically need to identify to a certain degree with the logic of that system, find it normal system. The world is like this. Everybody's working like this. So I do the same. And we do not question that anymore. And we become, as you say, perpetrator. This traumatic attachment, identification with the aggressor, with the different terms in psychotherapy that have been developed in the last 100 years.
There's the Stockholm syndrome.
Stockholm syndrome, yes. We find
well
it
known
normal.
from
And we find even that kind of arousing, exciting. I know there's a big problem that when people having lived through abuse, sexual abuse, they find it even sexually arousing or emotionally arousing to be related or in intimacy with abusive persons. So they will even go back to these again and again. And this is the spiral of re-traumatization, and you said it also, that can go from parents to their children. And I think it's very important that we are developing awareness of this mechanism of adaptation that at the first for the child is a necessary adaptation in order to survive. But later, if the adult is continuing in this functioning relational model, there's a high chance, there's a high risk that this adult will become also perpetrator towards other people.
Yeah. And you were talking also about EMDR at the beginning. Do you practice also EMDR with your patients?
Yes.
Okay. And is there an indication that because you've got many things that you can use, which is amazing as a doctor, and that's wonderful. You have got many tools. How would you choose, for example, between EMDR and the substances, for example, of breathwork? What would be the indication for you with EMDR?
I would start with EMDR, proposing EMDR, because it's still quite controllable how far you go. You can always. There's always this idea that the person can at any moment say, stop, I want to stop the process here, I'm done for today. Mm-hmm. And we make an exercise going back to a calm place, everything. So we arrange with that.
Yeah.
So in EMDR, the exposition will not be too challenging sometimes, but it can bring up lots of things already, lots of things. That is good. But with the substances, as you know, once you've taken the substance, there's no getting out of it for the next couple of hours or for the whole day. So we have to deal with it. And some people are afraid of this for good reasons. So I would rather start with EMDR than do breathwork. Okay. Because in breathwork, you can also get out at some time when it's too much. And really, when the person is really determined to go in a deep process, I will propose augmented psychotherapy.
All right. Yeah, perfect. So I guess we covered most of the... no, we didn't cover. We covered 10% of what would have been covered. But anyway, so I invite really everybody to have a look at your book. Available in German, I think, English and French now. Soon. Okay. All right. Perfect. Ansgar, is there, for people who are interested by your work, how can we follow you? How can they get information on you and your work?
It's basically on looking on videos, podcasts, conferences I give every once in a while. I don't have a real follow-up website for myself. I have not the resources, timely resources to cultivate that. But they're here and there, and there are updates on the internet that you can find. Google my name.
Okay. And people who would like to contact you, how can they do that?
They find my email contact on the web. They can contact me. Yes.
Okay, perfect. And maybe last, do you have anything planned in your next weeks or months, which is of big interest for you? It could be a conference, participation to a conference, or maybe a personal experience that is exciting for you in this field, of course.
Well, the most important event to come is my book getting out in France. I'm very excited about that. It's a long journey. I'm looking forward to this, and I expect that I will be solicited maybe here and there for interviews or newspaper articles. I'm looking forward to that, and I'm focusing on the opening of my book next.
Okay, perfect. So the book, reminder, Vampirocene, and the subtitle in French is?
It's in French.
In French, yeah. Well, anyway, so in French.
How to understand and overcome the traumatic entanglement that is the basis of the collective crisis of our civilization.
Okay, so that's a big program. Thank you very much, Ansgar.
Thank you, Arnaud, and I'm very pleased that you read my book in detail, because it's, as you said, dense, and I really appreciate that you are referring to details in my book. This discussion. Thank you so much.
You're welcome. It has been enlightening for me. So thank you so much, Ansgar, and see you soon.